Now we're going to talk about drugs that affect the urinary system. Remember, in the urinary system, there are 2 kidneys, 2 ureters, a urinary bladder, and a urethra. The kidneys filter all waste products out of the bloodstream, but allow these elements needed by the body to stay in the bloodstream. Here I have pictures of a cat's urinary system, and this would be either a male or female, a male dog's urinary system. This is a female cat. This is a male cat, and a female dog will have the exit very much like a female cat, a little bit lower. So just as an overview, we need to remember that sodium and water are linked together. So everywhere that sodium goes, water is going to go. They are best friends. Kidney function the kidney will receive 20 to 25% of the cardiac output. So it's very important in water conservation and hydration. It's highly sensitive to glomerular blood pressure and systemic blood pressure. If the pressure drops below 45 to 50 millimeters of mercury throughout the body, then the pressure in the glomerular capillaries is lost and urine formation will stop. That's called anuric, A-N-U-R-I-C. Part of what the kidney does is to regulate the RAA system. Remember, the renin, angiotensin, aldosterone system. This regulates, it also regulates red blood cell production. So erythropoietin is the hormone that's secreted mainly by the kidney in the adult, which acts on stem cells in marrow and stimulates red blood cell production. Diseased kidneys, if we have a diseased kidney, this hormone is secreted in reduced amounts or not at all. And so, when we have diseased kidneys, the animals may develop a non-regenerative anemia. Uremia can increase the sensitivity of some tissues to certain drugs. So uremia is essentially urine in the blood, but it's the toxins from the urine in the blood, so primarily blood urea nitrogen. So it makes changing that chemistry in the blood will sensitize tissues to certain drugs. Sensitivity to CNS depressants is increased, and therefore the dose of opiates, barbiturates, and tranquilizers should be reduced in uremic patients. Xylazine, orompin, and ketamine hydrochloride are both contraindicated in uremic patients. Any impaired renal excretion or biotransformation causes delayed elimination of many drugs and thus enhances their toxicity and their duration of action. So if you can't get the drug out, it's going to stay in the body and accumulate. Here's our regulatory hormones. These are hormones that influence the function of the kidney. Aldosterone. It works in the distal convoluted tubule. It's a mineralocorticoid, so aldosterone is secreted by the adrenal gland and works in the kidney, in the distal convoluted of the tubule of the kidney. What does aldosterone do? It enhances the reabsorption of sodium. Aldosterone, sodium. Aldosterone is a mineralocorticoid, and it reabsorbs sodium in the distal tubule. By doing this, it conserves water loss. So sodium and water come out of the distal tubule, so they don't get peed out. They get reabsorbed back into the water. This helps to maintain both blood pressure and blood volume. It decreases urine volume and concentrates the urine. Antidiuretic hormone does the same thing as aldosterone, but this is ADH. It is also known as vasopressin when it's used as a drug. What it does is it doesn't work with sodium. It decreases water in urine production, which concentrates the urine. It increases water retention in the body and the blood. It's also a potent vasoconstrictor, so vasopressing down on the vessels. It's produced by the hypothalamus and secreted by the posterior pituitary gland. Remember, that's one of 2 hormones in the posterior pituitary gland. What's the other one? Oxytocin. Okay, so ADH increases water, holds water in the body, enhances the reabsorption of water, and it constricts the blood vessels. So it's going to improve the blood pressure So it's increasing blood pressure. It is used to treat diabetes insipidus. Diabetes insipidus is when we have a lack of ADH, which if you have a lack of ADH, everything opposite is going to happen. All the fluid in the body is going to be just urinated out. We're going to have low blood pressure. We have to be very careful that we do not overhydrate the patient when we're giving vasopressin, because that drug is going to want to retain all the water in the body. All right, so aldosterone and ADH hold on to water. Diuretics allow more fluid to leave the body. We call it a diuretic that promotes the excretion of urine. When we say diuresis, we're increasing the excretion of urine sometimes by putting more fluid through the kidney. To diurese is the act of effecting diuresis. So you are causing diuresis. All of this is used to reduce hypertension, remove fluid from the body. It also helps edema. Diuretic therapy can do two things. It mobilizes the surplus sodium and water from the interstitial fluid compartments and then throws it into the tubules so it leaves the body. It also helps with restoration of balance between the daily intake and excretion of electrolytes and water. So when do we need to use it? Well, if we have edema and inflammation, allergic reactions, congestive heart failure, cirrhosis of the liver, or trauma. Brain swelling can cause fluid or even the brainstem to be pushed through the foramen magnum, so that is an emergency use for a diuretic. So here's an animal with ascites, a lot of fluid in the abdomen, probably due to cirrhosis of the liver or congestive heart failure, probably congestive heart failure. And so helping this animal relieve the fluid by making it pee it out is how we're going to use it. We can also use a diuretic to reduce intraocular pressure. So if we have glaucoma and we have too much fluid in the back of the eye or in the front of the eye and we want to reduce it, we can use a diuretic. Depends on what kind of glaucoma we have. And so there are a couple of times we'd use a diuretic and another time we might not. Also, if we want to do cataract or lens surgery, just in order to reduce the intraocular pressure so we can do it without causing a lot of damage to the eye, or if we have hypertension. Treatment for uremia or renal failure. If we have a diet with excessive protein, phosphorus, or sodium, this is going to cause renal damage, then diuretics will help to mobilize those electrolytes and get them out of the body. So it just helps things to flow better in the kidney. Side effects of diuretics. So because of what they do, we have to watch for electrolyte imbalances. It will lower sodium. It will make it pee it out so the water comes out too. So we're going to see a hyponatremia or a decrease in blood sodium. We can see hyperkalemia, so it'll retain potassium in relation to sodium. And this we can check by looking at the EKG. If we have a widening of the QRS, a loss of the P wave or tented T waves, this means we have some changes in the sodium and the potassium. Also, if we see dehydration or hypotension, that's because of the diuretics. Hypokalemia we can see hyperkalemia or we can see hypokalemia. This is a tented T wave, by the way. Tented T wave. Hypokalemia can cause heart muscle arrhythmia, tachycardia, paralysis or weak muscles, and ileus, which is when the GI system stops moving. This is a T wave that is opposite of what it should be. So different types of diuretics. Osmotic diuretics. These are active molecules that attract water molecules. They are carbohydrates, and they tend to be very large carbohydrates. They promote diuresis by exerting high osmotic pressure in the kidney tubules to draw fluid into the tubules. They hold and or draw water into the filtrate, and they have local or systemic effects. They are not involved with sodium or potassium, so they're not going to change the electrolyte balance. They just change water. We do have to administer these very slowly, so over about 10 to 15 minutes. Some common ones would be mannitol, very, very large carbohydrate, retains water in the renal tubules just by its physical presence. It is contraindicated if we have brain bleeds, intracranial hemorrhages. Why is that? Because when we give the large molecule IV and it spills out of the blood vessel into the brain, it's going to draw all the water with it. So it's going to create more of an edema. With glucose, think about it. Diabetes causes more glucose in the bloodstream, and then glucose spills into the urine, and those animals will urinate a lot. It's not as big as mannitol. It is osmotic. It draws water out of the tissues into the blood and then into the urine. Loop diuretics are more commonly used when we have chronic diseases. Loop diuretics inhibit sodium reabsorption, so they don't allow sodium to be reabsorbed. Where? In the loop of Henle, in the kidneys. They can cause hypokalemia because when potassium gets eliminated, sodium goes into the tissues. It does have a rapid onset, and if you haven't heard of this medication, it's the most common one used in vet med, I'll be really surprised, is furosemide or Lasix. This is a loop diuretic that can cause hypokalemia, and in some cases can cause hyponatremia. The sodium is in the tissue versus the blood. It causes the kidneys to excrete chloride and potassium as well, and we may need to supplement potassium if they're on Lasix long term. Some aldosterone antagonists. These are weaker diuretics. We call them potassium sparing because they only work on the sodium. Spironolactone is like aldosterone. Remember, aldosterone is a mineralocorticoid that comes from the adrenal glands. So this is kind of like supplementing that. It works in the distal convoluted tubule. Sodium is not reabsorbed, so water goes into the tubules with it. Potassium will stay in the body, so it's potassium sparing. So they will be hyponatremia, relatively hyperkalemic. So we don't want to supplement with potassium. Angiotensin converting enzyme inhibitors are things that we need to be careful with because they interact with aldosterone. Triamterene is the human label, same thing as spironolactone. So when we're talking about loop diuretics, we're often talking about furosemide. When we're talking about potassium sparing, we're talking about an aldosterone antagonist like spironolactone. Thiazide diuretics are like chlorothiazide or hydrochlorothiazide. These inhibit the reabsorption of sodium chloride in water. Their duration of action is longer than that of loop diuretics, so you'd give it less often. Carbonic anhydrase inhibitors. I have a picture of an eye here because this is really the only place that we use it, in the eye. These decrease the rate of carbonic acid and hydrogen production in the kidney, which promotes solutes and increases the rate of urinary output. This decreases intraocular pressure, or IOP, by reducing production of aqueous humor. It's not used to treat edema, it's used to treat glaucoma. So when you see carbonic anhydrase inhibitors, you're going to think glaucoma. So Diaronide or Diamox are the two that we will see with this. And this is carbonic anhydrase, means eye. Some other things that we might use in the urinary system would be urinary acidifiers or alkalinizers. We do have to be very, very careful with this because when we acidify, although we can prevent struvites, we can promote calcium oxalates. If we alkalinize, we can prevent calcium oxalates, but we can promote struvites. We have to be very careful with that balance. The pH can affect mineral precipitates in the urine. So When we see precipitates, we will see crystalluria, and then when we see crystals, we'll start to see stones, so urolithiasis. Acidifiers, like I said, they prevent struvites, but they can promote calcium oxalates, and opposite of that, alkalinizers, wow, can prevent calcium oxalates, but promote struvites. Changing the pH of the urine can alter the formation of some stones, and it can change, some change can predispose the formation of others. So you might be better not to change the pH unless you are sure you have one type or another. Dilution is the better option, because if we dilute it, we're less likely to form stones. We can urinate out the crystals and decrease the precipitates concentrating in the urine. In general, carnivores tend to have what kind of pH of the urine? Acidic. Okay, they tend to have an acidic urine or low pH, whereas herbivores tend to have a high pH. So alkalinizers, we must increase their water intake. Sodium bicarbonate is one that we can use. Potassium citrate is more commonly used. Acidifiers would be like D-L-methionine or ammonium chloride. Or you could use a diet that increases water intake, like Royal Canin SO, and it just increases their need to drink water, not through salt, but just an overall need to drink water. Another problem that we see with animals is urinary incontinence. When we urinate or micturate, our detrusor muscle, which causes the contraction of the bladder, must coordinate with the urethra or urethral relaxation. If it is pressing down and we don't have urethral relaxation, we will not have urination. So we'll see a loss of control, usually with age, and more so in which sex? Females. We think it's due to the slow decrease in estrogen, or sometimes it can be a fast decrease in estrogen due to a spay. We do need to rule out a urinary tract infection because that can cause urinary incontinence, or urinary incontinence makes it a urinary tract infection more likely. Also want to rule out tumors and a congenital abnormality. There are two that come to mind. The first is when we have a bladder that is more caudal, located more caudally. We call that a pelvic bladder, and there's not a lot of space between these bones for that bladder to expand, so they pee more readily. So especially when they lay down, that puts a lot of pressure and they will urinate more readily. Ectopic ureters are when we have a ureter that comes into the bladder and doesn't stop where it's supposed to. It actually goes down into the urethra instead of allowing the urine to accumulate in the bladder. So here's some examples of some contrast studies on the urinary system that shows us a pelvic bladder and some ectopic ureters. What can we treat? So if we see a physical or anatomic reason that this is happening, then we're going to need to do surgery. If we see a tumor, we're going to need to remove that. If there's a urinary tract infection, we need to use antibiotics, culture sensitivity antibiotics. If we have a disease, here's a couple of diseases that can cause problems with urinary incontinence. Urethral hyperreflexia, which is when we have spasms of the urethra, which will cause frequent urinations, and sometimes we see this after they pass a stone because it really irritates that urethra. So it'll just spasm and they'll have little spurts of urine coming out. Dyssynergia is when we have a lack of coordination between that detrusor muscle and the urethral sphincter. It's a problem because when they try to urinate, they can't, or if they try to hold it, they can't. So it's not connected, and that is essentially a blocked animal. Urethral hyporeflexia is the loss of tone of the urethral sphincter. It's where they just cannot close that sphincter. And then detrusor areflexia, there's no reflex to constrict the bladder, and nothing to hold the fluid in. So any pressure on the bladder, they're just going to leak urine. It's like having a water balloon that is not closed. So some incontinence medications that we'll use. Phenoxybenzamine is for when we have a urine retention or we have urethral spasms. It decreases the smooth muscle tone of the urethra, and it's good for obstruction, so it relaxes the urethra. So what class of drug would decrease the tone of the urethra? Something that was parasympathetic, sympathomimetic. Right? Is that right? Sympathomimetic? Okay. Something that will allow that to leave. So parasympathetic, sympathomimetic. Bethanechol is for detrusor areflexia, and it's contraindicated if there's any urethral resistance. So if we have any blockage of the urethral tract, we do not want to use bethanechol. So phenoxybenzamine for urine retention, and bethanechol. Some hormone-responsive incontinence drugs. Phenylpropanolamine, probably the most common one you see. We know it as Proin, PPA, or PPL. It is a supplemental adrenergic agent. It helps to constrict and strengthen the urinary sphincter and trigger vasoconstriction. It's associated, if we have side effects, they're associated with high levels. So we'll see increased blood pressure and hyperexcitability. So we want to decrease that dose. And often when I start an animal on this, I'll start at the recommended dose, and I will decrease it over time until we're at the lowest dose that will keep that animal from urinating. It could be decreasing the amount that I'm giving or the time that I'm giving it, so decreasing the frequency. Testosterone can supplement hormones and help with some control of the urethral sphincter. But some side effects with males would be prostatic enlargement, perineal hernia, and some behavior changes. So testosterone we would use more frequently in male dogs. Estrogen, diethylstilbestrol, or DES, supplements estrogen hormone. We can see it used in the male cat as well. We don't use this as often because the side effects are that we see signs of estrus, aplastic anemia, which means they're not making red blood cells because they have bone marrow suppression. So it's pretty severe side effects, and it can affect the human that's giving it, so you won't see DES given very much anymore, if at all. Amitriptyline is a drug of kind of more of a SSRI. It has some side effects: dry mouth, rapid heart rate, and sedation. High doses can cause a heart toxicity. We'll also see some poor grooming, especially in cats, and some weight gain. This is something that it treats the symptoms of idiopathic feline lower urinary tract disease. Mainly we're going to see these hormone-responsive incontinence drugs in older female spayed or neutered dogs. They're going to be dribbling when they're relaxed or sleeping. They'll be normal when they're awake. And we do think that sex hormones play a role in maintaining normal tone. That's it for the urinary system. If you have any questions, let me know.